Today I presented the sixth of 6 studies that show the improvement in response to ESAs by the addition of intravenous iron without any significant toxicity. I wish this cartoon was not true. We are in the midst of one of the most severe restrictions for a standard of therapy that had become routine in oncology in the United States. We are not, I will go over, I made the EMEA letters smaller because the restrictions are not as severe. We are not allowed to treat past a hemoglobin of 10 for chemotherapy-induced anemia. We are also not allowed to start until the hemoglobin gets below 10. So for the first time in the history of therapeutics, the end point and the starting point are the same. We are not allowed to treat cancer-induced anemia at all. That means anemia associated with cancer in patients not on chemotherapy. They are now eliminating our ability to use ESAs in patients who are receiving adjuvant chemotherapy because they're potentially curable, and any other advanced cancer that is potentially curable, such as small cell lung cancer and lymphoma, may not receive ESAs if the current restrictions go into effect. The EMEA does not allow the commencement of therapy until the hemoglobin is 10, but unlike the Americans, the EMA allows the treatment of to hemoglobins greater than 12, with reductions between 12 and 13, and then resumption at 75% of the dose after therapy is stopped once it reaches a level below 11. In a paper published in Expert Opinion in Emerging Drugs, John Glaspie showed that we spend 3 times the dollars on ESAs for 50% of the benefit in transfusion reductions, which is the indication for ESA, than the nephrologists do. The nephrologists routinely, 100% of nephrology patients on dialysis receive intravenous iron for their anemia care. And I'm sure that's an exaggeration, but it's an exaggeration by only a couple of %. In oncology, less than 15% of patients receive IV iron. In a paper that was presented just Friday at the Society for the Advancement of Blood Management in Baltimore, Dr. Patrick Lefevre, in a comprehensive mathematical model, showed that the increment in blood usage as a result of these restrictions can be predicted based on current transfusion practice to increase, because we are somewhere around the 50% reduction, an increase between 126,000 to 420,000 units of blood per year in the United States alone. I neglected to tell you that in the United Kingdom, the NICE guidelines, the National Institute for Clinical Excellence, recommend that ESAs be limited to those situations where there is a clinically significant anemia and transfusions are unavailable. That is a quote from the NICE guidelines. We do not have the available blood units in the U.S., and I'm certain in Europe as well, to handle the high estimate of red cell increment if ESAs are restricted. Michael Hedinas from Sweden showed that in patients with positive marrows, these are iron-replete patients. We're not talking about treating iron deficiency now. These are iron-replete patients receiving ESAs for anemia of lymphoma, not on chemotherapy, that there was an 11,000 unit mean reduction in ESA usage, translating to, at the price of the Swedish krona 18 months ago, $100 per patient per week savings. There are 492,000 of them in the United States and nearly 1 million in Europe. This was my data in 2004, showing that giving intravenous iron without any increase in toxicity was basically a slam dunk in terms of benefit, and in a cost analysis of my practice compared to the practice published in numerous studies on ESAs, we save $1,301 per 12-week period per patient, which is consistent with Michael Hedinas' $100 per patient per week. I did this in 2007, and Michael did his in 2005. The dollar has gone down. The lung cancer data that you see is basically for show. It's not statistically significant, and it's a small number of patients, but it's a giant number. This is the data that I presented a few minutes ago. Take a look at the difference. Take a look at the time to target. It's approximately a 4-week difference. In 4 weeks, the average number of doses of darbepoetin would be 2, or erythropoietin 4. That translates to approximately $2,000. Taking over the same period of time, it's $100 per patient per week. Multiplied by 492,000 patients in the United States and 1 million patients in Europe, for an average of 12 to 22 weeks per year, we're talking about $4 billion overnight for nothing. These, sadly, are the trends in testing and IV iron usage. You can see the nephrologists in the turquoise have now persistently and consistently followed iron parameters and used intravenous iron, while oncologists are actually testing less than they were in 1992 and using virtually no intravenous iron. And these data are current to 2006. They're starting to go up finally. It's estimated now that it's not 3, but approximately 12 to 15% of oncology patients are getting it. The response to IV iron has ubiquitously, in cancer and in nephrology, been completely unrelated to the perceived level of iron called the ferritin between 500 to 800, between 800 to 1200, and similar data exists for TSATs of greater than or less than 19, suggesting that we do not have iron parameters that predict the response to intravenous iron. Paolo Pedrozzoli, who was at this meeting, took patients only with ferritins greater than 100 and, not or, and TSATs greater than 20, randomized them to iron or no iron. You can see the difference there. By the way, the savings was $100 per patient per week. Bastite randomized patients who had a mean ferritin level of 240 and showed that there was a statistically significant decrease in transfusions when intravenous iron was compared to oral or no iron in patients receiving ESAs. When looked at in the nephrology, 14 years of experience in the nephrology literature published by Calanter Zeta in 2005 shows that there is no increase in mortality from any cause in patients receiving intravenous iron for dialysis up to ferritins of 1,200, which the medical community considers to be iron overload. So it is my opinion, for those of you that are old enough to remember the Lone Ranger, that ESAs in the Western blood supply will be rescued once oncologists embrace the routine use of this clearly effective, routinely safe, and inexpensive therapy. Thank you.